Well, hello and welcome. Welcome to this First Nations Peoples webinar hosted by SAHMRI, the South Australian Health and Medical Research Institute, and the Australian Bragg Centre for Proton Therapy and Research. And our theme is all about how can we close the gap in cancer. My name's Julie McCrossin, and it's my pleasure to be one of your hosts tonight. I was treated for stage 4 throat cancer back in 2013 with radiation and chemo, and it's always a joy to still be here. But let me begin by acknowledging that we're broadcasting to you tonight on the land of the Gadigal people, and I want to pay my respects to elders past and present. I'd also like to say thank you to our partner for this webinar, Cancer Australia, and to let you know that we're going to be travelling all over the country talking to people who've been treated for cancer and also multidisciplinary teams in Darwin, the Gulf country up in the Northern Territory, Adelaide, Albury-Wodonga, Canberra, and also Melbourne, and that's where we're going right now. And it's my great pleasure to welcome the co-host for tonight, Professor Jacinta Elston, Pro-Vice-Chancellor Indigenous at Monash University, and the Chair of Cancer Australia's Leadership Group on Aboriginal and Torres Strait Islander Cancer Control. G'day, Jacinta, and thank you so much for joining us.
Thanks, Julie.
We're going to have people who watch this either tonight with the broadcast or on YouTube, on our YouTube channel where this whole webinar will be, and also each individual video package that we'll be sharing tonight in our travels. And we use this term closing the gap all the time. What is closing the gap? What does it mean?
Well, Julie, before I go on to closing the gap, let me acknowledge also traditional owners, both where you are, but where I am here in Melbourne on the land of the Kulin Nations, acknowledge the mob from where I come from in North Queensland, but also acknowledge importantly the people who are joining us tonight in these conversations and the lands that they come from. And I guess I'd just like to also say before I jump into this that I myself am also a 17-year survivor of cancer. I'm a breast cancer survivor. And so I too have got my own personal history with cancer in the journey that I'm on. But you asked about closing the gap, and really we've had about 14 years of this Closing the Gap campaign in Australia. The campaign started with some advocacy from Tom Calma when he was a Social Justice Commissioner back in 2005. And of course, we're going to hear from Tom tonight. But Tom really advocated when he put down a report to the Commonwealth, to the government in 2005, really highlighting the discrepancy between life expectancy of Indigenous and non-Indigenous people. It took about 2 years, but from 2007 onwards, we've had an annual report by the government about what their efforts in closing the gap are. They've set national targets, and we've got agreement with Indigenous stakeholders and the key sort of peak bodies around Australia about what those targets are. So really, it's about sort of saying we know that Aboriginal people, Torres Strait Islander people, live a shorter life than the non-Indigenous population of Australia, and we want to bring the gap closer together. We want Indigenous people to live as long as non-Indigenous Australians live. And in a nutshell, is that the goal of your work with Cancer Australia's leadership group, that Aboriginal and Torres Strait Islander people live as long as everybody else? Well, absolutely. So the key goal for our leadership group, and again, Tom Calma, who we're talking with tonight, who you're talking with tonight, is going to, he's on that leadership group and a range of other Indigenous stakeholders from around the country. And really what's important for us there is to bring to Cancer Australia's table the Indigenous voice and our perspectives on what needs to be done to prioritise, what we need to prioritise, and then how we should go about trying to deal with what is a sort of a growing gap between Indigenous and non-Indigenous people in cancer mortality. And what's really important in that, Julie, I think, is the fact that cancer is now the leading cause of death for Aboriginal and Torres Strait Islander people. And we saw the cancer overtook cardiovascular disease in 2019, I think it was. Well, Jacinta, tonight is all about a small contribution in the conversation about closing the gap. So let's travel, first of all, tonight to Canberra. I welcome now Professor Tom Calma AO, who's got an extraordinary job to tackle smoking. Welcome, Tom. Can you introduce yourself and tell us about your job?
Tom Calma. I come from Darwin. I've got Gungarakan is on my mother's side and Iwaj on my father's side, but I live in Canberra now in Ngunnawal country, and I pay respects to elders all across the nation and particularly our youth who are going to be our future leaders and the custodians of our stories, our cultures, our histories and our languages. My role, I guess I have two roles. One is as the National Coordinator for Tackling Indigenous Smoking, and that's a program run by the Commonwealth Government. But I'm also on the Indigenous Cancers Leadership Group with Cancer Australia, where we look at all cancers, but particularly, my interest is around smoking and helping our mob to give up smoking or to not take it up in the first place, which is the best strategy.
Why is giving up smoking, reducing smoking, critical to closing the gap? Why is it so critical?
Look, the thing about smoking is that it has such a massive impact on our health. In the past, we thought it probably contributed to about 20% of the burden of death for Aboriginal and Torres Strait Islander people. But the more recent studies that were done by ANU and led by Dr. Katie Thurber looked at the 45 years and older study and cohort, a 10-year longitudinal study. And what it found, which was very revealing and actually a bit depressing, and that is that people over nearly 50% of all deaths for people over 45 years of age can be attributed to a smoking-related disease. And for those who are under 45, it's around about 37%. So we can just see how massive the issue is about smoking and the impact it has across our health. We often think it's just lung cancer, but in fact it contributes to most cancers, and but also cardiovascular and other respiratory issues. And it's not only people who are active smokers, but it's people who are exposed through secondhand smoke. And then if we look at mothers who are either smokers or are exposed to smoke during pregnancy, that also has a fairly significant impact on the fetus and newborn baby in both respiratory issues, asthmas and so forth, but also, it's what we call epigenetics, and it's a fingerprinting. So it's already, babies are born with a predisposition towards an addiction. So that's why we're very keen on targeting your mothers who are smoke or in the presence of smokers and trying to target the family unit, because everybody's got to recognise that we all have a role in this and changing it. But also a lot of attention is paid to our youth who don't smoke to make sure that they don't take it up. And if we can do that, we will make a big difference. But, unfortunately, when it comes to cardiovascular diseases, heart diseases, strokes and so forth, when somebody gives up smoking, there's a fairly quick response and your cardiovascular health improves relatively quickly, as does your respiratory. But it's when it comes to cancers, there could be a 20-year time lag from when you give up smoking or exposed to smoke and when you potentially can get a cancer.
What have you achieved so far that you think, well, at least we're starting to make progress?
What I run, the Tackling Indigenous Smoking program, has multiple faces to it. But one of them is a population health approach that's done through 40 teams located across Australia. And they're teams of 2, 3, 4 people, and they run a population health approach. So they're out there working with the community, in with groups to get them to understand about the impacts of smoking, both the detrimental impacts if you're a smoker, but the positive impacts when you give up. But also we look at the economic impacts. So that's one level. We also provide funding towards a program called Quit Skills, which is about working with people in the community and teaching them how to do a brief intervention, as well as the Quit Line enhancement, which is about placement of Aboriginal and Torres Strait Islander Quit Line officers around the nation. So it's a multiple approach. Primary health care through the Aboriginal community controlled health clinics plays a very big role, and the role of health workers and doctors and nurses and allied health professionals who do these brief interventions. And the first thing is to ask somebody, if they smoke, and if they do smoke, have they thought about giving up? Do they understand about it? And if a health professional, particularly a doctor, asks that question, we see a higher incidence of people attempting to give up. But state and territory governments, the cancer councils, and so forth, all run programs. So it is a fairly significant approach, but it is such a significant impactor on health that it is very important that we don't take our foot off the pedal, and we see the outcomes that we're starting to see now. Smoking has become a cultural activity for Aboriginal and Torres Strait Islander people. It was something that we learnt and that it was actually condoned by government when they provided cigarettes and tobacco in lieu of wages. And so that didn't end until the mid to late 60s when we got equal wages and people had to pay wages. And so we've got to try and overturn that cultural practice that we have for many people smoking. But we do know that we've seen some great results. 10, 15 years ago, over 50% of our population smoked. It's now down to about 37%. But in rural and remote areas, very remote areas, the incidence is much higher. So, it's got to be a joint approach, and it's something that we can do. And just in that last 15 or so years, we've seen that an estimated 50,000 people have given up smoking or not taken it up. Aboriginal and Torres Strait Islander people, absolutely fantastic. And that's estimated to have saved about 23,000 lives. And that's going by the data. It's the single biggest health intervention that's had the most success. And that's Aboriginal and Torres Strait Islander people quitting or not taking up smoking.
Tom, Calma, wonderful to hear about your work, and I know everyone watching this is going to do what they can to support your work tackling smoking. Thanks for talking to us.
Thank you, Julie. And remember that we've just seen World No Tobacco Day, and the theme this year was Commit to Quit.
Thank you, Tom. Thank you.
Thank you.
And with us is Professor Jacinta Elston, the chair of Cancer Australia's leadership group, working to close the gap in cancer. And I should say, Jacinta, we've had a question coming in, are we working as well to close the gap in childhood cancer? And I'm assuming the answer is absolutely yes. But what's the key thing you'd like to emphasise there with the remarks of Tom Calma? Some good news, but some tough news.
Yeah, look, I think importantly what Tom's showed us in that little bit was just, change is possible. It is possible, and I think we're hearing that story a lot from some of our speakers tonight, that with a bit of effort you can actually make a difference. And so Tom's comment about 23,000 lives saved, whilst that might not sound like a lot, 23,000 in a relatively small population, Aboriginal and Torres Strait Islander people, is important. And I think on the issue of the childhood cancers, I don't think that we've really had a strong focus yet on childhood cancers. And I think that's something that we've got to do more to focus in on and think about. And Tom himself acknowledged the importance of youth. They're our future. And so I think, with time, we'll hear about optimal care pathways as we go on tonight. But I think with time, we'll start to be able to focus in on particular population groups where we're having serious sort of issues.
Thanks, Jacinta. And if you're watching us now live and you'd like to send us a comment in chat or in the Q&A, please do, and I will answer whatever we can. But on our journey around Australia, looking at closing the gap, let's travel now to the far north of the Northern Territory, to Borroloola. Well, look, welcome, Annie, to this discussion about your special project in your community. Can you introduce yourself and tell us what your job is and where you are?
My name is Annie Taylor. I live in Borroloola, Northern Territory, in the Gulf of Karpany area. And in that community, we have 4 clan groups, language groups. So there's Yanyuwa, Garwa, Mara, and Gurangi. My language is Yanyuwa and Garwa, and the two that's most spoken in Borroloola. I'm employed by the Cancer Council, NT, and in this project, it is to improve cancer outcomes in the Borroloola and Gulf region in the Northern Territory. And this project is funded by McArthur River Mine Community Benefit Trust, in with collaboration with Cancer Council Northern Territory.
Can you talk to us about what you do when it's discovered someone in your community's got cancer and what you do to try to help them get well?
Because Borroloola is such a long way from Darwin to their treatments, our clients are scared to travel. They don't like travel long distance. So my job is to try and break that barrier for being scared and being away from family and being away from community, country. Yeah, it's a different environment for them to go for their treatment.
How is it different? What's Borroloola like compared to Darwin?
Borroloola is like, it's isolated, so there's so much bushland, and they, whereas in Darwin, you got big tall buildings and hospitals and doctors and nurses, and medicines. Yeah, different sorts of machineries they got there. Yeah, and they're scared of that.
Can I ask you, how do you help people not be scared?
By talking in language and supporting them, encouraging them, because they know me and I speak language too, and they trust me. Their trust is very important.
Explain that. Why is trust important for getting people to get treatment?
Because they have to trust somebody who's working in the health center to give them good information about why they're traveling for treatment to Darwin. Yeah.
I've had cancer and I had to have 30 days in a row of radiation to my neck, and you had to have every day. And how do you encourage people to stay the course of the treatment, whether it's 5 days, 10 days, 20 days? That must be hard for people to be away from home so long.
I explain in a simple English, in a simple way, in language, why they're traveling and why their treatment is very important. And I say to them, if you miss that appointment or treatment, you have to start over again, Or sometimes if you don't go back and have this treatment, your cancer will spread and doctor won't fix it quick enough.
Are you able to travel to Darwin with them?
No, I don't. But I do have a co-worker who lives in Darwin and works with me, and she supports them there at hospital in Darwin.
What are you achieving? Do you feel you're helping people get well?
As a worker, everyone I found who I supported right now is happy what I'm doing and supporting them, encouraging them, and make sure, they're not scared and they're not alone going through this journey with cancer. When they're scared and then they just run away and hide and stop treatment, and it's too late for treatment then when they want to come back. But when you're there and supporting them, it makes them easy, and that then they got someone there for support.
And can you tell me a bit about yourself? How did you start working for Cancer Council Northern Territory, and how did you get involved in this work?
I'm a registered Aboriginal health practitioner. I'm from Borroloola, but I was living in Darwin and working from the Royal Darwin Hospital. I was doing hearing, so I traveled out to remote communities with an audiologist. He would do the hearing test, and I would do the treatment.
And so you obviously enjoyed that work. And how did you get involved in this particular project with cancer?
I left Darwin and came back home to Borroloola because I had to care for my grandson who came into my care. A nurse came up and asked me, there's a job going out, looking after clients and doing education and prevention, and I like helping people. Yeah.
And Annie, how do you think we can prevent people getting cancer, your people getting cancer? Where do you see the hope? Where do you see the progress there?
I sometimes walk around in the shops when people sit down. I talk to them individually, about signs and symptoms, signs of cancer, and encourage them to go for the regular checks, with the doctor, and that's where you can, find cancer too when you go for your yearly checks.
Is there anything else you'd like to tell us about your work that you're doing that you're proud of?
Well, I support families with, they in palliative care too, and end of life situation where their life is at the end, and I support families around that too.
How do you do that, Annie?
I sit down and talk with them and what they want, and because the doctor will be explaining to them what's going on, and I'm there to break it down in a simple English language, to what's going on. Yeah. Cancer Council South Australia, they provide training, quit skill course, like quit smoking. So they coming down here next week, and it's around pregnant women and young mothers. Yeah, this just supporting them how you can talk and encourage them to quit smoking, but helping them out, because it's their choice whether to, because nicotine is so addictive, but we're trying to work around in helping them quit smoking.
And are the people from South Australia coming to Borroloola to do that?
Yeah, Cancer Council South Australia coming up to run this course.
Oh, that's great. And, in your experience, how hard is it for people to give up smoking? Are people trying to do that in your community?
Yeah, there's a lot of people that is trying. I'll tell you, I used to be a smoker. I gave up 9 years ago because I know it was killing me. I said one day I just gave it up. I went cold turkey, yes. And I never looked back ever since that day, 9 years ago, when I gave up smoking. But it's individual how they give up, how they stop smoking and when to.
What has been the positive for you of giving up smoking? You look happy when you say it.
I smile every day. I thank myself for not smoking every day. Ever since I gave up, that's the beauty of it. Yeah, and I still have that smile with me. Yeah.
Just my final question is: there's a lot of head and neck cancer in the Gulf. A lot of people get head and neck cancer, and I've had head and neck cancer myself, so it's something I care about. Are you able to help people with that treatment, which can be very tough when you have to have a lot of radiation and chemo, sometimes surgery? How's it going in your community if someone gets head and neck cancer? Has anyone had it in your community?
Yeah, there was few who had head and neck cancer.
It's a tough one, isn't it?
It is a tough one, and I'm still learning myself, how to deal with it. Sometimes it's so personal, and it's hard to talk, but it's hard to talk about it, but somebody have to do it.
Yes, it's a cancer that more men get than women.
Yes, it's more male, and I can't help them with that.
I was just thinking that because of men's business and women's business, does that make your job a little bit hard sometimes?
Yes, it makes my job a bit hard, and having a male worker would be really good for the male patients because with men's business, in our culture. I think it's everywhere in Australia too. Yeah.
It'd be good to have a female worker and a male worker to really help all the cancer patients.
Yeah, because they can have cancer anyway, and in private areas you can't talk about. Yeah.
I understand.
Can I just say one more thing? With education and prevention, I go to the high school and teach the younger teenage ones, how to eat healthy and exercise and, what foods are bad for you. And I'm teaching them to look for signs of lumps and things in their parents too, all the grandparents and encourage them to go to the clinic and get checked up. Yeah.
Is there anything else you'd like to say?
We got a card, and for each cancer is it's a optimal cancer care pathways, and we use that as a guide too.
Okay.
Yeah.
Explain what that is. That card, that optimal care pathway. How does that help you in what you're doing?
It explains it properly in simple way. Yeah. When you got cancer and you got all these words, you have to break. It breaks down in a simple way. And and when you've got somebody and you want to explain it to them what cancer they have, and you got that optimal care pathway there to help you. Yeah. And having early detection and treatment and aftercare.
Well, Annie, thank you so much. That was very helpful to us and wonderful to hear you from all the way from Borroloola.
Thank you for that. Yeah.
And one day I'll come to the Northern Territory. May I come and see you up there?
Yeah, you can come to Borroloola. It's about 980 k's east of Darwin. You're going towards Queensland border.
Well, thank you so much, and I look forward to talking another time.
Yeah, thank you, Julie. Nice talking to you too. See you.
Well, we just saw there on that map the extraordinary distance between Borroloola, where Annie Taylor is working, and Darwin. So let's travel now to Darwin, to the Alan Walker Cancer Centre. Well, it's my great pleasure now to welcome Michael Penniment. Michael, thank you so much for joining us. Can you introduce yourself and give us a sense of what you do and where you do it in the Northern Territory and South Australia?
Sure. Yeah, thanks, Julie. Michael Penniment, as you say, radiation oncologist, and I'm director at Royal Adelaide and also one of the founding directors up here at the Alan Walker in Darwin. I've been doing a regular clinic up here for nigh on 20 years and continue to do so.
And what I want to do is focus for most of our conversation on what you're doing at the Alan Walker to close the gap and improve the life expectancy and the quality of life for Aboriginal people who've been treated for cancer. But just for the uninitiated, can you give us a sense of the scale of the problem when it comes to the different life expectancy and quality of life issues for Aboriginal people with cancer, particularly up north?
Well, I think that the couple of things that sort of bring it home quickest is that there's a significant excess death rate. In other words, Indigenous patients with the same cancer at the same age, same stage of their life are more likely to die from the same cancer than a non-Indigenous person. Overlay that with the fact that that also applies to all Australians that are away from a major centre in terms of country and remote. And so you put those two things together in the territory, and you've got the issue of there's clearly access to treatment, there's the distance, there's cultural issues, and there's also lifestyle issues in terms of some of the cancers that are most affected up here, lung, head and neck, and ones that we know have a relationship to consumption of alcohol and cigarettes. And so really the problem ranges all the way through to education of what causes cancers and hence prevention, picking up cancers at an early stage, right through to treatment, and then ultimately after treatment, it's how do you follow people up to make sure that their cancer's cured and that whatever the side effects of the treatment, that they've been fixed.
Look, I just want to give people a quick visual of what you've just said. This is from Cancer Council Northern Territory, and it shows that if it's dark red, it's excess deaths from all cancers. And people can see there that up north, and you're in the Alan Walkers at the Royal Darwin Hospital, it's tremendously red. And when you go to head and neck, which you've mentioned, which I'm always keen to highlight because I've had it myself, again, excess deaths from head and neck cancer up there, they're massive. That red means it's the highest level of excess deaths. So I want to focus on what you're doing at Alan Walker. What are you doing there that is making a difference to help both assist Aboriginal people to attend a full course of treatment and also to get some support in that rehabilitation or recovery period?
I think legitimately I can speak for our staff that the first thing we've done is that we really care. And we really see it's a problem and we try hard. And that sounds pretty simple, but it's an extra layer to reading a report and going, oh, there's a problem. We should do another report to work out what we need to do to fix it. Certainly up here, there's an awful lot of patients that just whenever there's something that might improve things, then they do it. The first thing we did was just getting the federal government and building the cancer centre sort of over 10 years ago now. The reports prior to the Alan Walker starting suggested that approximately 22% of patients with cancer were getting radiotherapy. And within sort of 8 or 9 years of operations, we've more than doubled that to 48%.
And why is that important?
That's important for a whole lot of reasons. The WHO suggested that of all patients with cancer, something like 48 to 50% of patients would benefit from radiotherapy. So not every cancer, there's certain blood-borne cancers and various others that you wouldn't give radiotherapy, but basically about half the patients with cancer would benefit from radiotherapy.
And so, Michael, if you were going to sum up what difference it's made for Aboriginal cancer patients that you've now got the Alan Walker Cancer Centre in Darwin, and you'll have staff that really care, what impact has that had on completion of treatment and, I guess, increased survival?
Yeah, well, absolutely. I think that the message has gone back to communities, and it's oral history is important, and there's nothing more important than a community elder who's gone to Darwin. The community might not have seen the person for maybe a few weeks, but they've come back well, and they've been cured. And that we're really over the 10 years starting to see that oral history come through, where we've got so many Indigenous supporters to say radiotherapy is pretty straightforward. I got maybe my chest area got a little bit irritated. It all got better. I'm cured. We're starting to, so the retention rate in terms of the percentage of patients that come and have treatment and have the full course has gone up over the last couple of years from still fairly high in the sort of 80% to really in the very high 90s. And what we want to do, because I think in my journey over the last 20 years, there's also there's an attitude amongst health professionals of, rather than having that discussion and customising the treatment for the person, there's assumptions and patronism in terms of, I don't know if he'll come up for his treatment. I don't know, let's give them, instead of giving 30 treatments for cure, let's just do 5 because he might not finish. Whereas I think now we're dispelling that. We've got good data, the data that we've presented for our college journal quite recently, and other data that says if you explain things well and you craft the course of treatment, then patients, Indigenous, non-Indigenous, whatever background, if you make the effort to explain it, they will have the standard treatment and stay for the course.
How important is it to have Aboriginal staff involved?
Absolutely vital. Up here, Barb and her team are great. there's challenges that they face because it's not, we talk about Indigenous patients, but there's so many areas. There's obviously communities around Darwin, but Tennant Creek, Catherine. We increasingly are trying to treat more people from the top end of Western Australia. Each of those communities, there's language differences, there's trust differences, there's a different elder structure. So our staff, Barb, I keep saying Barb is amazing at being able to breach that. So and to get communities from wherever the patient is involved.
Can you just tell me, Barb, a little bit more about Barb? Who is she and what's her job, just in a nutshell?
Yeah, Barb's the Aboriginal, the Indigenous Liaison Officer, and I think that different centres, and Royal Adelaide obviously has a team of Indigenous Liaison Officers, and I think that up here, one of the important things is to have somebody that's in the centre who is absolutely a trusted member of the Indigenous community. So it's not Michael from Adelaide saying, "Oh, you need to have that treatment." It's somebody that's sort of got that trust, and also who knows people who knows people who knows people, so that if there's, I don't know if I want that treatment. Barb's got great contacts in terms of, I'll get so-and-so to have a chat or whatever. And really, I suppose Barb's got a good network and she's trusted.
Thank you so much, Michael, for talking to us. Thank you.
No worries. Thanks, Julie. Good.
Well, it's my great pleasure now to welcome Giam. Hello, Giam. Can you introduce yourself and explain what you do at the Alan Walker Cancer Centre?
My name is Giam. I'm the Clinical Executive Director at the Alan Walker Cancer Centre for Radiation. So my background is from Adelaide with radiation oncology as a radiation therapist, but currently I'm managing the radiation oncology unit.
What are you doing that you're most proud of to try and change what you've just told me so that people are diagnosed early, get the treatment they need, more of a chance of living and recovering, and also prevention? What are you doing there at Alan Walker and in that community you're proud of?
I think when the cancer centre first set up, obviously we were a bit green behind the ears in terms of engaging with Aboriginal people, but with a lot of cultural training and also with learning, we managed to infiltrate the trust. The key word is trust, and trust from Aboriginal communities is the key in how to start engaging with any of the practitioners or any of the community elders group. So gaining that trust and having a reputation to be able to implement collaboration strategies is the key. So we started engaging with many health practitioners in the community. So we started a couple of training programs, which is a Cert 4 training program in cancer care. And in terms of delivering cancer care, there's no one better than the primary care providers. So we had a program where we can upskill and provide the knowledge for primary care workers or clinician or practitioners to able to identify, detect early, to able to care for the patients while they're having treatment, to care for them while they're returning from treatment. And the most important thing about that training is to create a network. We need to have the direct network. That means they can access us directly without going through an intermediary source or another health jurisdiction.
So you're trying to avoid that desperate dilemma of delay that can be so deadly in cancer.
And if you look at the optimal care pathways, sometimes the delay is caused by so many factors, and many of those factors are not clinical factors. They could be family factors, they could be community factors, they could be even logistics or even referrals. Some patients just get lost because somebody forgot to follow up an appointment. So most of the communities in Northern Territory, we have got ambassadors, what we call people who we train. So they could be either chronic disease care coordinators, Aboriginal health practitioners, or even community Aboriginal workers. So we got people who we can contact if we're sending somebody back to the community. So what we do currently is all our head and neck patients have got a comprehensive handover to the community team. Because, for example, a patient goes home and some clinical centers do not dispense certain type of opioids or even soluble Panadol or certain creams, or even the dietary requirements are not there. So different community centers have got different facilities and different resources.
You believe that we need an Aboriginal cancer unit. Just very briefly, if you would, what do you mean by that and why do we need one?
The key thing I was saying earlier about trying to get an Aboriginal cancer unit is to be able to facilitate from primary care to acute care and back. An Aboriginal person from the community would like to have the same face and the same person or the same unit to communicate with, rather than, oh, I'm so afraid to see the next person, or I don't know what question, and you're not comfortable and you're not, unable to relate and engage with people. And we have interpreters, and interpreters play a key role. And every facet of care is done by various different personnel. So somebody to coordinate, or a unit to coordinate all those different providers of care is the key to providing comprehensive care for Aboriginal people.
I hope we both live long enough to see an Aboriginal cancer unit in Darwin. Giam, thank you so much for talking to us and giving us this time. We really appreciate it.
You're welcome.
And welcome if you've just joined us. And co-hosting this special webinar on closing the gap in cancer is Professor Jacinta Elston, who's from Monash University and also the chair of Cancer Australia's leadership group looking at cancer control for Aboriginal and Torres Strait Islander people. Golly, you've seen so much there, Jacinta. What would you like to highlight? I'll tell you in a second what a few of our viewers are saying, but what would you like to highlight in the work at Darwin and also, of course, with the marvellous Annie Taylor in Borroloola?
Firstly, I think what was really important, what came out very strongly from both Michael and Giam, is the issue of high-quality cancer care that's delivered in a culturally contextualised space. That they're not talking about minimising the care that they provide. They're actually realising and recognising that they need to give the best care to patients with the greatest needs. And I think, Michael's comment about not altering a care pathway, but actually making sure you achieve it was really important. And I think Giam's comments about the way that they've got to restructure the service delivery to suit what's going on with communities is just absolutely the example of what we need to have happening around the country in the various places where Indigenous people are getting services from cancer care. I think for Annie, look, what a beautiful soul, and the messages that she shared with us was amazing. So firstly, she reiterated the importance of youth, which Tom Calma has also spoken about. She re-spoke about the importance of prevention, smoking and food choices, and focusing on youth. But also she talked a little bit about self-care, which I think was just really important. She spoke about how she smiles every day because of the decision she made to quit smoking, and that was really lovely. But it's important to remember for people like Annie, they're working in their community. They're working with their family, with their community, and this is hard work. So it's really, they're really impassioned Aboriginal health workers, Aboriginal health practitioners. It's really important to them.
And it was great to hear how valued they were, I thought, by Associate Professor Michael Penniment, the radiation oncologist at the Alan Walker Centre. Can I say one of the comments from one of our viewers is that trust is coming through as a major theme and how critical that was. And just this word trust, and the role of the Aboriginal health workers is very strong. Another viewer has asked, this technology we're using tonight, can it be used to link Aboriginal health workers across communities and also to support them, and a tribute to Annie specifically from someone who's heard about her work discussed at a conference and how there is people are being diagnosed earlier in her community because of her work. Could I just have one quick comment of my own response from you, Jacinta? As I listened to Giam, because I have had head and neck cancer, I know that there's quite a deal of pain management involved, not just during the acute phase of treatment, but in the follow-up. And we did see disturbing data on the extent of head and neck cancer in the north of the Northern Territory and across the north. And when they go back to communities, Giam was saying that there aren't necessarily the capacity to give certain pain medications. And I have to admit, my heart squished there. I wonder if there's work to be done there in terms of empowering the nurses to be able to prescribe the appropriate pain relief for people rehabilitating back on community.
Well, I think that's the important that Giam sort of spoke about in the context of making sure that when people leave the Alan Walker Cancer Care Centre, that they've got a coordinated care plan for after, so that they know what community they're going back to, they know whether or not those drugs are available and whether or not there's somebody who can help them. So, that means that the cancer care centre themselves have to be so much more ready to be supportive of the patient after they walk out their doors, and they can't lose sight of them, particularly in places like the Northern Territory.
Yes, exactly. I mean, that's right. Giam did emphasise dramatically and significantly the role of primary care.
And he spoke to that issue of telemedicine as well, Julie, of course.
Well, that's right. That's very true as well. Look, thank you. We did hear a reference there to the team of Aboriginal health workers at the Royal Adelaide Hospital. So let's go to the Royal Adelaide Hospital. Well, Lynne Thorne, it is my great pleasure to welcome you to this conversation. Can you tell us what's your job and what do you basically do?
My name is Lynne Thorne. I'm an Aboriginal health practitioner in the Royal Adelaide Hospital, and my job is actually to be with our patients because they come from a vast area of Australia, mainly up in the Northern Territory. They come down without any family, and I'm there to be their advocate, to be a friend. We do have younger ones, so I'm also like an auntie. So I take on all different roles, but to deliver the same thing and just to make sure that, they are comfortable and knowledge of what's happening to them, without fear.
And why is it important to have Aboriginal staff, Torres Strait Islander staff working with patients and families? Why does that make a difference in terms of the results in health?
I think there's always that fear, and it goes in history that if Aboriginal people go to hospital, they're never going to come out. So it's really good to have an Aboriginal person there because we relate to them a lot better. We understand, some of us have got, the language, we can understand them. So there's those barriers that we can work with. But more to the point that, they feel safe having their own people around.
Lynne, you're an auntie. What does that mean and how does that help the patients and families you're with?
Okay, so I'm actually 65, and I guess at this stage of my life, I can be called like auntie or nana or sister or whatever. So in Aboriginal culture, we take on different roles, and people will automatically look at you. If they're younger, they'll call me auntie or nan. So sometimes I have to use the auntie way of speaking to my patients or being a nana, just to comfort them, to make them, feel that they are looked after by a family member. So I guess that's where I fit in as an auntie or a nana.
I've come to the Royal Adelaide Hospital and I've seen the Aboriginal and Torres Strait Islander unit. And, you come in the front door of the hospital and even before you go into the main hospital, you turn to the left and there's a completely separate unit with a great big lounge room. You walk in and there's a wall with all Aboriginal faces on it and your names. There's a garden you can have, an outdoor area, a barbecue. There's a lot of Aboriginal staff. How does that help people to keep coming each day to accept their treatment and to give them a better chance of survival?
I guess that's also a add-on to the cultural safety thing, you know, about actually having a place where they can sit and, you know, just get help. And basically, you know, like if I was a patient walking in and I knew that was there, I'd be going, oh, you know, I feel good now. You know, I feel good that there's a place where I can go, that you know, a lot of people don't want to face other people, so they've got that space to feel comfortable. So that also helps in the healing process, having someone always there to talk to or whatever, because a lot of people have come down to Adelaide and they've never been to Adelaide or a big city. So it's about, you know, making sure that their spirit is safe.
As I mentioned to you before, I've had cancer myself, and I had radiation and chemo, and I had to turn up every day for radiation 30 days in a row. How do you help people to keep coming every day? Are you able to help with things like transport or accommodation when people have come from a long way away?
Yes, that's a part of what we do, is that when patients are coming down, we already know they're coming down, and so we work with PATS, patient assistants, and they organise them to go into hostels, and we have what we call corporate shuttle, which is used for transport. So they get them in and out on for their appointments.
You mentioned that you can speak to people. Do you ever use interpreters? You know, because there's so many different Aboriginal languages, aren't there, spoken all around where you are and up north to the Northern Territory?
Well, we're very lucky because we have what the service called ABC interpreters, and we have Aboriginal interpreters that speak a number of languages. So we're very lucky.
You know, traditional healers, that word, is it Nungcurry? I might be saying it incorrectly.
Nungcurries.
Does that
yes.
come into your role there?
It does. And we're very fortunate that we've got the Nungcurry service, and that they get treated, and it's all under Medicare, which is fantastic.
I didn't know that. Can you explain what a Nungcurry is and why that would really help your people to feel more at home and more safe when they're getting their cancer treatment?
I think with traditional Aboriginal people, they always used the healers, you know, when they were all in their communities, and they probably still do. To have it here in Adelaide is like, you know, that's a part of their healing. As soon as you mention like Nungcurries, they you know, bring them in. You know, and the Nungcurries are really good. I've actually used them myself at certain times, and I believe, you know, they're a good part of the healing journey.
When I came to visit the unit in Adelaide, I was shown that you've got some different clothing. There's like an area where you've got clothing. Can you explain why you provide clothing for some people if they want it?
You got to think like Northern Territory is quite warm, you know, and when they get here, they come down in just whatever they get on the plane with, and when they get here, they get cold. So we've always got that, but we also have patients that don't have very much, and they can just go in and help themselves. It's just about providing stuff that they need.
Thank you so much for talking to us, and what a credit to them back in WA, because it inspired you to do all the wonderful work you're doing now. It was absolutely wonderful to speak to you. Thank you so much for this interview.
Thank you, Julie. Thank you.
Well, it's my great pleasure now to welcome Denise to discuss what's happening at the Royal Adelaide Hospital, to try and close the gap in the cancer results for Aboriginal and Torres Strait Islander people. Can you introduce yourself, Denise, and tell us what your job is?
Yes, I can. Well, Nina Mani first, which is greetings in Kaurna language, because I am sitting on Kaurna land. So that's a little way I acknowledge the Kaurna people of the Adelaide Plains. My name is Denise Karpany, and I'm the Strategic Project Officer for the Central Adelaide Local Health Network. A huge part of my role is looking at the strategic policies and plans and the Aboriginal Health Plan for Carlin, specifically Aboriginal focused policies and strategic plans. While my role is not a huge lot of patient contact, but with the small team that we have, I do often have a lot of patient contact.
And I should acknowledge that I'm on the land of the Gadigal people in Sydney, and to pay my respects to elders past and present. So thank you for that reminder of what I should have done right at the start.
Oh, you're welcome. I mean, I always do that all the time, even when I answer the phone. And so that's another little education, because I'll answer Nina Mani, Aboriginal and Torres Strait Islander Health and Wellbeing Hub, and people make the assumption that my name is Nina. So I give them a little bit of an education session there, so we'll know it's Kaurna language and I'm greeting you.
People who are watching this are interested in what they can do to help close the gap when it comes to cancer and Aboriginal people. What are you doing there? We've heard quite a bit about it, but what do you think you're doing there that shows how to help close the gap? What are the main things you're doing and that more people need to do across Australia?
Well, one of the first things that we just finished working on is an identification project, which specifically means a lot of Aboriginal people are not identified when they come into the hospital, and so if they're not identified, they're not put on our list, and so they don't get the support and services that that we could offer them while they're there, unless we find them ourselves or other family members. Now that I've played a huge role in that campaign. It's part of the national campaign, Asking the Question, and it's basically collecting more accurate data for the hospital, but also accurate data for us in regards to just identification plays a huge role on what we can do to put in activities and things and programs to work towards closing the gap together. But I will say that we can't do it on our own. We've got to work together with Aboriginal and non-Aboriginal people. And closing the gap, not just on cancer, but on all health aspects and life expectancy as well.
And that educational role with non-Aboriginal health staff, what needs to happen? In your experience, what is effective in really making people not just aware, but motivated to learn more and help make a difference?
I believe that it needs to be compulsory within the health system. Other places it is compulsory to have cultural awareness, cultural sensitivity, cultural safety or security, whichever term you want to use. And currently that's part of my role in providing those sessions for the staff within Carlin, and we've got over 12,000 staff. So on a regular basis, I do smaller sessions as well as bigger sessions to provide information, but also tips to help people working with Aboriginal people. It's sad to think that in my time working here, non-Aboriginal people seem a bit scared and a bit hesitant when approaching Aboriginal people or talking to them and trying to get information out. And so that's part of my role. So I've just finished doing some with some new nursing students, and I also do it once a year with Year 6 medical students, so that's before they actually come out of university. And benefit of that, this year they're just asking me to do a second one. So because of the makeup where our patients come from, our catchment area is all of South Australia, all of Northern Territory, Eastern Western Australia and Western New South Wales and Victoria. So we'll get Aboriginal and Torres Strait Islander people coming from those areas as well. So when I do my talks and sessions, it's not totally specific, because you can't be because of the makeup of the clientele. So it's a general session, making them aware of the huge number of Aboriginal people across this country. Language is a huge issue. People still believe and think that we only have one language, and it's not so.
But can you describe for us 4 or 5 of the most common language groups who are coming to you, just so people hear the names?
Okay, Pidinjara is one of the bigger ones, and people would have heard APY lands. That's the Unangul Pidinjara Yankarijara lands, and that covers 3 states and territories. So it's the north of South Australia, part of Western Australia, Northern Territory. So that is the biggest one from South Australia, but we tend to use Aranda. That's the language around Alice Springs. Walpri, which is a little bit further out, and all the Yolngu language from the top end from Arnhem Land. So yeah, Aranda, Pidinjara, Antigirinya, Walpri, Luritja, they're some of the most common that we need interpreters for.
Do you think that's still something people need to learn and understand, that culture is very much alive and language is alive in a huge area of Australia?
Yes, I do. Plus, that's a passion of mine. Prior to coming to work for health, I worked in an Aboriginal community-based language centre. They were set up all over Australia, and it's about preserving, recording and maintaining the languages of South Australia. Yeah, I think it's very important. But there are also, people can learn as well, the languages if they want to. Part of who my family is, I'm a Ngarrindjeri, Narungagana and Nunjamatana woman, so that's saltwater, freshwater and rock people. And people can learn those languages as well. So some people might say that our languages are dead, and they're not. We call them sleeping, and I'll say to people when they say you can't because you've got so many, well, yes, we can. And if you look at the Hebrew language, that was lost for hundreds of years, and that was revived and retrieved, so we can do it here.
Denise, our time is up, but what's going to close the gap, and how long is it going to take when it comes to cancer?
Wow, that's a huge one. I mean, cancer's hit my family really hard. My mother had both bowel and breast cancer, and I lost my older sister to cancer. Sadly, out of 8 children, there's only me and my younger sister left, and she's also got cancer. She's got 3 different types. What it's going to do is it means all of us need to work together, whether we're Aboriginal or non-Aboriginal, and the health profession need to start really thinking outside the square and start really listening to what people are saying to them and what is working. What we're doing now, and it's just been established as an Aboriginal community reference group, and it's all linked in with the National Health and Safety and Quality Standards, and one of them is consumer participation and consumer engagement. So we've just had our 2nd meeting, and that's people who are consumers, who are the users of the service, people who have been patients, so that they're going to have a huge input into developing our Aboriginal health plan and looking at the plans for cancer and other chronic diseases. But we have to work together and don't always, think outside the box. But it's getting the health profession to do that is a bigger task than what we think, but we're not giving up, and we'll keep fighting to the end.
I want to thank you so much for talking to us. I also want to just say how sorry I am that your family has been so toughly impacted by cancer. And how much I respect the work that you're doing with the other Aboriginal staff there and those who support you. Thank you so much for talking to us.
You're welcome. Thank you. See ya.
Well, we'll shortly be travelling to our last destination on this webinar this evening, to Albury-Wodonga, but I'm pleased to welcome back Professor Jacinta Elston, who's our co-host tonight. And Jacinta, we've been getting comments from the Central Coast of New South Wales and also, I think, from Adelaide, applauding the work of the people we're seeing. What strikes you about the work that we're hearing about that you'd like to emphasise as important in closing the gap?
I think I'd really like to mirror your comment at the end then, Julie, Denise's story, her own personal family story, reminds us that behind the numbers of families and community members that are known to the Indigenous people who are working in these systems, right? So, cancer is the leading cause of death for Aboriginal Torres Strait Islander people. That means that those colleagues of ours that are working in the system, the Indigenous colleagues, are going to be impacted by cancer in their own personal families. And, that requires support. And so I think that's really important acknowledgement for us to place. And we heard a bit of that, I think, as well with Annie earlier. But of course, Denise's story is very much a tragic sort of story of family loss. That's heartbreaking. I think both Denise and Lynne show us the importance of connection. Lynne's comments about being an auntie and the importance for mob to be able to come into the hospital system and be able to connect to an auntie is really important. And it doesn't matter if that auntie doesn't come from your community. The fact is our mob will associate that this person is an auntie. It does bring me back to the point that Annie made before about men's and women's business as well, and making sure that we've got a balance in male health workers. I think that's really important. And the other thing that was really important that came out of that was the flexibility and support that can be built within our healthcare systems to bring Indigenous mob in the way that they need to. So, Lynne's comments about the use of the engagement of nunkeries in Adelaide Hospital. That's amazing, that model. And so that only works because of great colleagues and great systems sort of support. And I acknowledge the comment from Alan, who's a colleague of, I think, of Lynne and Denise's in the comments, and he's, acknowledged them for their great work. But it works because they've got the respect of their colleagues. And again, you see there's Denise's work, working on cultural capability building, helping to provide projects that will help strengthen the way that the non-Indigenous workforce in the hospital systems can engage with Indigenous clients. This is all really important stuff.
Yeah, thank you so much, Jacinta. We're sort of learning so many tough things, but also gaining so much hope and inspiration from the Indigenous health workers themselves. But look, our final destination, viewers, is Albury-Wodonga, and we're speaking first to Dr. Craig Underhill. Joining us now from Albury-Wodonga is Dr. Craig Underhill. Craig, can you introduce yourself to our viewers?
I'm the Director of Cancer Services at Albury-Wodonga Health, and also I'm a Clinical Director with the Hume Region Integrated Cancer Service, so that extends across northeastern Victoria and into New South Wales. So we're on Wiradjuri country here. You can see Lake Hume in the background. I put up, there's a photo of Bell Bridge. I got sick of the Golden Gate Bridge on the Zoom background. And I saw some data recently. I know you do some work with Jacinta Elpston, and she gave a really impassioned call to action at a ministerial roundtable at Parliament House recently. She showed some data where because the peak of smoking cigarette use in the Indigenous population has only been recently, we'll see unfortunately an increase in incidence in lung cancer for another decade or two. In the in the European population, we went through a peak in smoking usage in the last 20 or 30 years, and as a consequence, the incidence of lung cancer has fallen. But unfortunately, mostly driven by cigarette abuse, we're going to see a rapid increase in cancers in the Aboriginal and Torres Strait Islander population. That's the expectation. So although it's a small population, there's a lot of work to do, and obviously there's an intersection with distance and access to treatment, social economic disparity, and so that all intersects and makes the we really all need to roll up our sleeves to address this issue. And I know that Cancer Australia and the Australian government has a focus on inequity and the problems in the Aboriginal and Torres Strait Islander population with cancer going forward in a new cancer plan that's being written.
And just to be, so I'm really clear, that ministerial roundtable, that was in Canberra, was it? So that was a national roundtable? That's
right. It was just recently. And so we were out of lockdown, and it was one of the first face-to-face meetings for many people. We met in the Great Hall in Parliament House I think there was about 60 or 80 people with great consumer representation from the Aboriginal and Torres Strait Islander population, and a whole lot of cancer experts. I often get dragged out as one of the regional experts, and so it was great to be there and give some input in the very first framing of the National Cancer Plan, which will be a 2-year process, lots of consultation.
Okay, so action happening to close the gap.
We've done some cultural training with the workforce, and that's ongoing. So that's really important. A small example is that the Aboriginal flag is flying outside along with the Australian flag, and I heard Lyndon Burney talking on ABC Radio, one of the House of Representative members, who's Aboriginal woman, and she was saying that she goes to schools now and they all have the Aboriginal flag. So, I think in recent years, and they all do the welcome to country at the start of the day. So there's been, some small steps like that. We also did a piece of work in conjunction with Cancer Australia a number of years ago. One of our project officers led that, and it was called Yarning in Lung Cancer. And so it was to raise awareness of lung cancer and the issues of smoking and lung cancer in the Aboriginal and Torres Strait Islander population. That's available online on the Cancer Australia website. So that was some educational modules. So that was a really great piece of work, which was co-designed with the local population and the Albury-Wodonga Aboriginal Health Service, who I think you've interviewed. In the next 2.5 years, in the Victorian Cancer Plan, there's a whole piece of work to implement what's called the optimal care pathway. So as you know, for every tumour, head and neck, lung, breast cancer, there's a framework for the best way to manage a patient, and there's a specific one for the Aboriginal and Torres Strait Islander population with cancer. So we'll be starting some work broadly in Victoria, including regional Victoria, over the next 2.5 years to start implementing that framework.
In a nutshell, is one key part of that it sets what should be the time frame for certain testing, access to treatment, further testing, follow-up. I'm a cancer survivor myself, and there was this whole path that you go on, and it's trying to set time targets so there isn't delay. Is that a critical part of it?
That's exactly right. And what support services should overlay that whole process to support the patient and their family.
I see.
I would like to mention one other great program that we're involved with, Julie. We just received some funding from the Medical Research Future Fund for regional Victoria, a program called Revitalise, and an element, it's looking at some health services research that will answer regional specific issues. So we're looking at programs in teletrials, so running trials, clinical trials by telehealth, the geriatric oncology program, palliative care trials, supportive care trials. But there is also an element in Indigenous health. And so we've co-designed a program with the Victorian Aboriginal Controlled Health Organisation, and we'll be working within our region in Goulburn Valley to pilot some programs. And we're looking at barriers for Aboriginal and Torres Strait Islander people with cancer accessing clinical trials and looking to overcome the barriers to clinical trials. So we've taken that optimal care pathway and just taken the clinical trials part and doing some a deep dive and trying to resolve that issue and to get more people onto clinical trials.
Craig, I'm just so grateful to you for taking time from your patient work to join us for this webinar. Thank you so much.
Not at all, Julie. I mean, I think all of us in the cancer field see this as a really, really important issue that we need to tackle. And so I think everybody, has a desire to do that and to partner with the Aboriginal organisations to try and make some inroads.
Thank you.
Thanks, Julie.
Well, now we travel a couple of suburbs across Albury-Wodonga to the Aboriginal Health Service. We're travelling now to Albury-Wodonga, to the Albury-Wodonga Aboriginal Health Service, and welcome to you, Ricky. Can you introduce yourself and tell us how long you've been a client of the service there in Albury-Wodonga?
Hi, I'm Ricky Williams. I've been with AWAS for about 15, 16 years. On and off, my partner comes here, my children come here.
Tell me, what sort of cancer did you have and what sort of treatment did you get?
I had rectum cancer, and I had chemo for 24/7 around me, and then I had radiation for 6 weeks. And because it was right on Christmas and they wanted to sort of do it twice a day, they did it at 8 o'clock in the morning. And then I went back at 3 o'clock in the afternoon again and did another bout of it. And that went on for 6 weeks. And then they went in and operated, took the blockage out, the tumour out. And then I went back for another 6 weeks of radiation and chemo. And we've just about got it, I think, at the moment.
How long ago was that, Ricky?
About 5 years ago or more, a little bit more now.
Tell me about the different help that you got from the Aboriginal Health Service.
I had people drive me wherever I had to go. Giam sort of took over everything as far as making the appointments, answering to the appointments. All that sort of thing was all sort of bypassed around me myself, so I didn't have to do any of that. Even the transport was supplied for me, so yeah, it took a great burden off my... And that's what I was saying before. I can't understand how these older people actually do it without a partner or something like that, you know.
Did you ever have someone from AWAS come with you when you had appointments? Did someone ever come into the appointment with you?
Yeah, quite often Fiona would pick me up and take me over to my appointments and things like that, and she was an advocate for me as far as even hospital. She'd come in on several occasions to help me in hospital and things, and even after the cancer. Since I've had the cancer, I've had pneumonia a couple of times. And just one experience, I went up to the hospital and they were going to discharge me, and Fiona actually stepped in and stopped them, and it was 3 weeks later that I actually got back out.
What you're describing, they sometimes call navigation, you know, that helping with appointments and so on. If you hadn't had that help, who would have made your appointments and kept track of them all for you?
I have no idea. I honestly don't know, because, I mean, I got appointments 5 minutes after they gave me an appointment, mate. I had no idea. AWAS always sent me out me reminders and things like that, so I was always ready to go, you know, when I was being picked up and things like that. But I would never have made it by myself, no way in the world.
If someone's watching this, Ricky, and they've never visited an Aboriginal health service or really met anybody who uses them or works at them, how would you describe that service there? What does it offer people? What's it helped you with over the 15 years?
Well, mate, I mean, from time to time, they've even got food in the waiting room, you know, like you can pick up some peaches or some oranges, something like that. You don't see that in a normal doctor's surgery or anything. And it's not run like... It's a bit different to like a normal stuffy doctor's surgery, eh? It's sort of a bit more relaxed and things like that. And so I find it quite homely in that.
And what makes it seem homely and relaxed? Can you think about it?
You get to know everybody. You know, it's not like you see one doctor scooting through or anything like that. You know most of the doctors and you know most of the people because they're either the drivers or one of the doctors or one of the counsellors or something like that.
Have you ever had any other sort of, services through the Aboriginal Health Service?
Yeah, I just had all my teeth done. And I'm just waiting on my denture now. Well, that only cost me $300, which it would have cost me with a private practice. It would have cost me about $1,200. So, yeah, they've done a lot for me as far as that goes.
That's fantastic. I just think having the dental care there is, why is that important to you?
Probably just vanity.
Well, there's nothing wrong with vanity. Is there anything else you'd like to say about, your experience with cancer and the health service? This is all about trying to talk about closing the gap so Aboriginal people have an equal survival rate and equal recovery.
Yeah, well, I was watching a guy the other day here at actual AWAS. He was trying to get through to one of the girls out the front about an appointment when she said, I have to make it for a week's time. And she was so diplomatic the way that she went about it. This guy wasn't accepting the fact that he had to wait a week for an appointment. But the young girl behind the counter, mate, she was so diplomatic about it, eh? And the guy ended up having a bit of a giggle by the time he left, where if he'd been in a normal doctor's surgery, mate, they would have got quite perturbed with it and thrown him out.
It's been fantastic to talk to you, Ricky. Thank you so much.
Thank you very much, eh?
And I look forward to seeing you with your new teeth. My dad was a dentist.
Thank you. I hope your future's good for you too, Doc.
welcome now to Fiona. Fiona, can you introduce yourself?
My name is Fiona Bradbury. I work for Albury-Wodonga Aboriginal Health Service as the Chronic Disease Coordinator.
Tell me the challenges that many of your clients face when you're supporting them to get through the cancer.
So basically the obvious challenges for people is cost. It's about the financials. It's also about how they're going to get to the appointments. How do they remember the appointments? So that's where my role comes into it. That's my job. I coordinate multiple appointments, whether or not they need x-rays, allied health appointments, specialists. I also work with the Primary Health Network and I'm able to fund consults. Transport is offered via our Aboriginal outreach worker or AWA's transport.
And why is transport so critical, particularly in a rural area like Albury-Wodonga? Explain where Albury-Wodonga is for our national audience.
Albury-Wodonga is on the border of New South Wales and Victoria, and the Murray River runs between it.
Would you have many patients who are travelling distances for their cancer treatment?
Yes and no, because my role actually goes up to the northeast region. So I have patients in Wangaratta and Benalla. So yes, that was quite challenging at times to get people to their oncology reviews. So again, I rely heavily on my chronic disease outreach workers to do the transporting for me. So I work under the umbrella of a program called the Integrated Team and Care Program. So this is a program run through the primary health networks, and I'm very fortunate enough to sit in the AMS. So with this program, it is exactly that. It is about closing the gap of ill health of Aboriginal people and recognising that chronic diseases are actually in fact killing people if left untreated. So what that looks like, it's more than cancer. It's about respiratory disease, it's cardiac, it's kidney disease, it's diabetes and cancer. So we are able to have funds to get people to specialist appointments. We are able to provide transport. We are able to liaise, advocate for our patients, attend appointments with them.
Fiona, you have a number of services coming in from outside, don't you? Tell us what agencies come into the Aboriginal Health Service.
We have a legal service that visits weekly. We also have a representative come from housing. We also have somebody coming from Centrelink. And this helps people because, saves them going and waiting in long lines. They have access to make appointments here. And so, for example, Centrelink can get online immediately and access their files from our service.
When I visited Albury-Wodonga Aboriginal Health Service, the architecture and design of your service is absolutely remarkable.
AWAS is an amazing building. It's quite beautiful and homely. So when you enter into the reception area, it basically is divided into two, and it's kind of a rounded horseshoe around a beautiful garden. So when you go to your right, you're in the social and emotional wellbeing team, which is where our counsellors, mental health workers, our outreach workers that assist with drug and alcohol. We have an NDIS support coordinator in there as well. Then when you go to the left of the building, that's where our clinic is. So we've got our GPs, we have our practice nurses, we've got a child and family health team as well, and we've got a midwife as well that looks after our pregnant mums. We have access to allied health as well, which is fantastic, full allied health. So we have our diabetic educators, our podiatrists, speech pathology, we've got dietitians, we also have a physiotherapist that's here once a week as well. Basically, AWAS is a one-stop shop. We also have visiting specialists as well that come here. We actually have a psychiatrist that comes here, a nephrologist, and a paediatrician.
Well, Fiona, thank you so much for talking to us for this program. Thank you.
No worries, thank you.
Well, we're joined now by Megan. Megan, can you introduce yourself and tell us what you do there at Albury-Wodonga?
Yes, I'm Megan Clayton. I am the Aboriginal Chronic Disease Outreach Worker.
And what does that mean, outreach worker?
Well, in a nutshell, I assist patients with appointments to specialists. I work alongside Fiona in her role. So I take them to their appointments as needed, sitting the consult with them as well, and go from there, help them on their journey.
I'm very interested in how you help people to both to understand and to remember what's happened. Can you talk about that a bit?
Well, usually I sit there and take a lot of notes. I do, because I have had that experience where the person has stopped listening after you hear the C word. So I tend to take a lot of notes. So afterwards, I'll sit down with our clients as needed and go over the information again with them, just to see what they have missed, what they don't understand. If they do need to chat with their doctor again about what's going on, then I'll organise that as well.
And tell us about the transport. I know there's a practical element of just getting the person to appointments on time, but there must be a big emotional support role in that too, is there?
Yeah, it's actually really good transporting the clients, because I get to know them on a more personal level, because we don't just talk about cancer. We talk about other things, what's going on in their lives, and that's where you can pick up other issues they're having, whether it be social and emotional wellbeing stuff or something the social worker might need to assist them with. And that's a really good opportunity then, or just generally how they're feeling, you know what I mean? Like emotionally, you know, they might be more likely to have a chat with me than they are with their partner or someone else.
Have you got any thoughts on what more we could do to close the gap? You know, what are there challenges that your clients are facing and you think, golly, I wish we could do more about that?
From what I've seen, like going to the cancer centre here, and I did actually originally go to the Wodonga one as well, and I was only discussing this earlier, I think we need more Indigenous workers in these places, you know, because a lot of our clients do see an Aboriginal face and it is a relief.
And tell us a bit about yourself, your own background and how you got involved in cancer work and Aboriginal health.
I'm actually a middle-aged Aboriginal woman. I'm Wiradjuri. I grew up in Wagga, and Leeton. I actually started out in childcare and then got the opportunity to do an Aboriginal traineeship for enrolled nursing in Wagga. So that's how I started the nursing side of things, and then I got a job at the AMS in Wagga in the chronic disease role there as care coordinator. So that's how I started off there, and I've worked in chronic disease now for about 10 or 11 years within the Aboriginal community. So, and I love it.
Well, look, thanks so much for talking to us. It's an absolute pleasure to hear about your work, such vital work and in our efforts to close the gap. So thank you so much.
My pleasure. Thank you.
Well, very shortly we're going to close with just a moment by the Murray River, but it's welcome back to Professor Jacinta Elson. Elson, what are you thinking? What would you like to leave us with? What have we gained about closing the gap tonight, Jacinta?
I think there's a couple of things, Julia. And look, again, how fantastic have your speakers tonight been? They've just been, the speakers, the people contribution, the contributions from people has been great. I think the importance of cultural liaison officers, cultural care workers, the discussion around cultural safety should be reminding us that there is still ongoing work to do around the prevalence of racism and systemic bias. That's what's not really being spoken about in a lot of ways tonight. But, I think that racism, systemic bias in our care systems and in our structures means that we've got work to do on an anti-racism agenda. We've got more work to do, and that's really important. I think it's really great to see that mentioned in that last video, particularly about the Aboriginal medical services and the role that they play in being critical partners to the cancer care centres. And lastly, I think, we've heard it quite a lot about the optimal care pathway and the importance of the optimal care pathway. And if people get to have a look at that, they'll see that the optimal care pathway highlights 7 critical steps in a patient journey. And so that's really important to think about, from that prevention work through to the end of life. And even just there in that last video, we heard about the importance of having an Aboriginal legal aid group come in. to an Aboriginal medical service. That can be about, writing wills and helping prepare for some of that end of life conversations that needs to happen. Lastly, Julie, before I finish, I'd just like to say I'd like to pay my respects and honour all of the Aboriginal Torres Strait Islander mob that have been part of these conversations with us tonight, because, it's their work and their efforts, their passion, and I honour them for that. But I acknowledge again the fact that this impacts on them personally in their lives and in their communities and families, and, that they themselves will have had their own cancer journeys, as may some people who have joined us tonight. And so I acknowledge all of those people. And again, Julie, thank you for including me and creating a space for me to be a part of this conversation tonight. But also I want to wish you well on your own cancer survivorship journey.
And back at you. Thank you. And thank you so much for being part of it. And, everyone who's watching tonight who's registered will automatically receive a recording of this webinar. And I was thinking we should send out to everybody information about the optimal care pathway, because it's been mentioned, from across the nation tonight. Look, I want to thank SAHMRI, the South Australian Health and Medical Research Institute, for their support for this series of 4 webinars, the last one tonight, and also the Australian Bragg Centre for Proton Therapy and Research. And if you Google SAHMRI, 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 the YouTube channel that all these videos are on, the individual packages for all 4 webinars as well as the total webinars are on that YouTube channel. And if you've enjoyed this and learnt a lot, please help us to distribute and promote this important opportunity to hear these frontline workers trying to close the gap in Aboriginal health. And thank you so much to Cancer Australia for being a partner tonight. And I want to say a huge thank you to Daniel Taylor, who's in the room with me at this moment from Insight Media, who's played a critical role in the production of this series. I think you'll agree, just quite remarkable incorporation of the images, which has so enhanced the discussion. And he's also been very, very helpful around editorial decision making. And I want to close with, a very personal walk along the Murray River with a dear friend of mine, Leonie McIntosh, a Wiradjuri woman, a woman living with the tough results of cancer treatment, still alive, still with us. And Leonie, we all love you. Let's go to the Murray.
When I feel pretty yuck from the cancer journey, sad or grieving, when I get really scared and anxious, I have to go connect with country, and I have to take that time out. They call it Yindamara, time to listen, to be still, to be quiet. And I know I definitely need that during my cancer time, because if I don't be quiet and I don't be still and I don't gain that energy and love from the earth, Wiradjuri country, I'll get disconnected. Watching the river flow kind of takes away the grief that's there. It kind of, you can mourn and grieve with the river. You can take some leaves off the tree and you can say, I no longer want this pain, and throw it in the river. We'll place our hands to gain strength and to ask permission to take some leaves to help us with our grieving. And if you notice, it's dead calm. So we have that permission to take the leaves from the tree. And I'd like to share them with you. And I'll go and take some of these ones for me. Thank you. to country, regardless of being, you know, an Indigenous person or non-Indigenous person, regardless if you're born in Australia or not born in Australia. Water is central to life. Water is very important, and the river is especially important for me. Take away the grief and all the hurt and the loss.
I wonder if we'll hear the kookaburras today. Thought I heard one earlier on. Coo, 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 coo.
Yeah, and the river, she keeps calling out my Nabila. She keeps calling out my Nabila. She keeps calling out my name.